Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about coding for cardiac conditions. And now I'd like to introduce our industry guests for this episode. We have Elise Christensen, RN, HCS-D, HCS-H, HCS-O, COS-C, OC Advisory Board Member and Coding Manager with Hartford Healthcare on the call today. Elise has been an RN for over 34 years. Currently, Elise is serving as leader of the Coding and OASIS Review team for a large hospital-based home health and hospice agency. And we also have Kelly Kavanaugh, RN, HCS-D, HCS-H, HCS-O, BCHH-C, OC Advisory Board Member, and Independent Home Health and Hospice Consultant, owner of the OTB Group Incorporated. Kelly has been in home health and hospice for 30 years. She's worked as an agency owner and administrator, a DON, done billing and claims, been a field nurse, done marketing, served as a director of education, QAPI, and OASIS Review and Coding. She has been coding and OASIS certified for over 15 years. Thanks for joining us today, Elise and Kelly.
You're welcome.
Let's kick things off with an audience poll. All right, our question today is, which of the following is your biggest challenge with cardiac coding? And our answer options are provider documentation, clinical documentation, specificity, or something else. And if it's something else, if you can just choose something else and then type that into the chat pane or the question box, then we can discuss that when we look at these results a little later in the call. All right, folks are slowly making their choices, I see. We'll give it another second or two to try to gather as many responses as we can. And then I'm going to close this out and we'll talk about the results a little bit later in the call. All right, I think we are slowing down, so I'm going to close this out. Thanks everybody for voting. I think this will be interesting after our discussion today. All right, listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane and we'll try to get to as many of them as we can. And now we're going to move on to our topic, and that's coding for cardiac conditions. Elise and Kelly, I'm going to turn things over to you, but please let me know if I need to advance a slide, if I run behind or anything. Thanks so much for putting this together.
Our pleasure. So we could talk for a long time about cardiac diseases, but I wanted to focus on some of our documentation challenges with acute MIs and CHF and our valvular diseases. But starting out with documentation challenges, our documentation for coding cardiac diseases is critically important, and we need to have clear and specific documentation from our provider. We also need to recognize the key terms and the phrases that are used in cardiac documentation and know what signs and symptoms are integral to those medical conditions that we're coding. We also need to know the convention and the guidelines, how they apply, read our includes and excludes notes. There are many combination codes in Chapter 9 and linked conditions using the with convention. Last, we need to understand the circulatory system integrates into almost every other body system, and we can find close ties to other ICD-10-CM chapters. In certain scenarios, we may need to look beyond the circulatory chapter to properly code a case. Our provider documentation needs to be clear and concise. That is vitally important in coding our cardiac conditions. The coder is cautioned in the chapter introduction not to attempt to decipher or discern what a provider might be saying in their notes. If we need additional documentation, we should query. Some examples would be atrioventricular block. Is the block first degree or second degree? Does it involve the right or left bundle branches? Is it another conduction disorder? Heart failure. Is it left-sided heart failure? Is it systolic or diastolic or both? Is it congestive? Is it acute chronic or acute on chronic? Atherosclerosis. Does it involve a native artery, an artery from a bypass surgery? Are there other signs such as intermittent claudication, rest pain, ulceration, or is gangrene present? So diving into myocardial infarction guidelines. If a patient with a coronary artery disease is admitted due to an acute MI, the acute MI should be sequenced before the CAD. If a type 1 non-STEMI evolves to a STEMI, then the guidelines tell us to assign the STEMI code. If a type 1 STEMI converts to a non-STEMI due to a thrombolytic therapy, it's still going to be coded as a STEMI. We code I-21.9 acute myocardial infarction unspecified as a default for unspecified acute MI or unspecified type. If only type 1 STEMI or transmural MI without the site is documented, then we are instructed to assign code I-21.3 ST elevation MI myocardial infarction of unspecified site. If an acute MI is documented as non-transmural or subendocardial, but the site is provided, it is still coded as a subendocardial acute MI. For subsequent acute MIs, we have additional guidelines. A code from category I-22, subsequent ST elevation MI, and non-ST elevation MI is to be used when a patient who has suffered a type 1 or unspecified acute MI has a new acute MI within the 4-week time frame of the initial MI. A code from category I-22 will be used in conjunction with a code from category I-21. The sequencing of those two codes from I-22 and I-21 will depend on the circumstances of the encounter. We don't assign a code from I-22 for subsequent MI other than type 1 or unspecified. For a subsequent type 2 acute MI, we only assign a code from I-21.A1. For our subsequent type 4 and type 5 acute MI, we assign only a code from I-21.A9. It's not common for us to see these, but in some of our larger institutions, we may see this specificity of documentation. If a subsequent MI of one type occurs within 4 weeks of an MI of a different type, we assign the appropriate codes from I-21 to identify each type. We don't assign a code from I-22. So codes from category I-22 should only be assigned if both the initial and the subsequent myocardial infarctions are type 1 or unspecified. And Kelly, I'm going to turn it over to you now.
Okay, that was a mouthful with the heart attacks. That's probably one of the trickiest things we code. I feel like in the cardiac arena, but heart failure can be tricky too. So let's talk a minute about heart failure. This slide kind of gives you some definitions, which I'm not going to read to you today just for the sake of time, but this information is for you to have to reference back to on the different types of heart failure and how it affects the heart itself. But when you're looking at lists of documentation or sections of documentation throughout your medical records when you're reviewing, it's important to kind of pick out some of these terms and watch for some of these terms. And sometimes it's tricky because it's not always straightforward information. So some of the things you're going to look for, the systolic and diastolic, which we mentioned a little bit earlier. You're also going to look for terms about acute and chronic and try to get the feel for, is this a new situation it's occurring for this patient, or is it something that they've had in the past that is now becoming exacerbated? or having an acute component to a chronic condition. Next slide. Okay, so along with looking at your documentation for things like acute and chronic and diastolic and systolic, some of the things that you might see as far as hidden documentation, what I kind of was alluding to there was this, you'll see it on this slide, you have HF, and this one says MREF. Sometimes you will see HF with a letter R and then EF. And sometimes you will see HF with the letter P and EF. And those are actually indications of diastolic, systolic heart failure. So your R is close in the alphabet with systolic with S. So that's how I remember that little R means reduced contractility and stuff of the heart. So the reduced heart failure is your systolic heart failure. And then the P is your preserved ejection fraction, and that's your diastolic heart failure. So a P, kind of, if you turn it upside down, kind of looks like a D. So that's how I remember the diastolic with the P. So those two. And then we confuse things further by adding in now this MR. And MR can mean mid-range, or it also could mean mildly reduced ejection fraction. And if you put it in your head as mildly reduced, I think that helps me to remember how to code it, because a reduced ejection fraction, the R, is systolic. So a mildly reduced ejection fraction is still reduced. So it would be coded as systolic heart failure. So then there's an example here on this slide for you. That was also in some publications and some information coding advice on coding assignments back in September of 2020. So heart failure, just if you remember, and one of the things I wanted to point out too, it's not really pointed out on the slide necessarily, but when you're looking at acute versus chronic conditions, sometimes you might see some conflicting documentation in different sections of the chart. So just remember that even if it doesn't come out and say something is a chronic condition, by indicating a patient has a history of congestive heart failure, that would be a chronic condition. So they've had this condition for a long time, as opposed to an acute situation where this just came on. And that could, make a big difference when you're talking about teaching and training to your home care patient. If they've never had CHF before and this truly is an acute onset, you're gonna need to do a lot more teaching and training with this patient. It can help justify your care. So that's just my little point out there for your CHF.
Thanks, Kelly.
You bet.
And moving on to valvular diseases, these can be a little tricky too. Our valvular diseases can impact one valve in the heart or multiple valves in the heart. They can be described using a lot of different terms like insufficiency, regurgitation, incompetence, prolapse, stenosis, obstruction, even combinations of these problems, or just terms like failure, other specified diseases, or even unspecified valvular disease. Pay close attention to the alphabetic index when you're searching for valvular diseases. Some of the valvular diseases individually are assumed to be rheumatic and some are not. Diseases involving multiple valves are assumed to be rheumatic unless our provider documents that they are not rheumatic. The next slide has a quick reference to some of our most common valvular diseases based on the most recent guidance and code and clinic advice. In this table, you've got the 4 valves on the left-hand side, and across the very top of the table are the different conditions that we can see in those valves. If a provider specifically states rheumatic or non-rheumatic, we use our index and follow the with subcategory instructions. Our categories I05 through I09 include diseases of the heart valves, and diseases of the mitral and tricuspid heart valves are considered rheumatic, unless specified by the provider. It could be our physicians, our NPs, our PAs, as non-rheumatic, with the exception of mitral prolapse, incompetence, insufficiency, and/or regurgitation, which codes to non-rheumatic. Aortic and pulmonic heart valve disease is considered non-rheumatic unless it's specified as rheumatic. So we need to pay attention to that provider documentation. When we have multiple valves involved, the ICD-10-CM classifies the disease as rheumatic unless that provider specifically says they're non-rheumatic. Again, pay special attention to the provider documentation and to your includes and excludes one notes. The bottom part of the table shows our valvular diseases involving multiple valves, which is assumed to be rheumatic unless otherwise specified.
Thanks so much, Elise. And there's some references here for folks if you want to do further reading or further study on this topic. Thanks for putting this together, Elise and Kelly. It's really helpful. I think folks will find these slides a good reference in the future. So let's take a look at our poll and we can chat a little bit about the challenges folks are having. Oh no. Elise, can you hear me?
Yes, I can.
Oh, okay. I'm sorry. My computer just reset and I was concerned that I had been logged out. Okay, great. Thanks for confirming. All right, let's share that poll and get things back on track. Okay, so we asked you which of these following items were your biggest challenge with cardiac coding, and the most challenging aspect is provider documentation we found with the folks on the call today. Elise and Kelly, any thoughts about that? Are there particular issues that you see with provider documentation that folks might be tripped up by, and maybe suggestions for getting documentation that makes things a little easier?
Sometimes it does take a little digging to find the provider documentation and the specificity that we need. When a provider has diagnosed a valvular disease, for example, if we have an echocardiogram or some other type of test in the chart that gives us that extra specificity that we need for the diagnosis that the provider has already made, it's good to read through that test and find out, did they specify which valves were involved and what the problem was with those valves?
That holds true for congestive heart failure as well. One thing I want to caution though, when you're reading an echocardiogram and you see the diastolic dysfunction, which is a very common thing to see on an echocardiogram, that if you have a diagnosis of congestive heart failure, that information is helpful as far as choosing the correct diagnosis code. But if your patient does not have congestive heart failure, that diastolic dysfunction does not diagnose that condition. So just be careful with that. If you see the diastolic dysfunctions and you have hypertension, you can always code that under hypertensive heart disease. If you also see cardiomegaly, you can code that as well in that hypertension and use that I11.9 code, which is your hypertensive heart disease without heart failure. So just be careful you're not diagnosing your patients with heart failure when you don't have that from your physician directly.
I am so glad you pointed that out, Kelly. You're right.
Yes, that's tricky.
Good tips. So the runner-up concern was specificity. Are there any common pitfalls with that? I'm assuming that's a documentation-related issue as well.
One thing I was going to suggest too, I have seen a lot of referrals that come from skilled nursing facilities and rehab facilities, and sometimes the specificity is truly not there on those reports. They may or may not have specific codes. They may just have congestive heart failure, just speak to congestive heart failure. and the specificity is not there. But if you can get a hold of the hospital notes that led to the SNF stay or that led to the rehab stay, those usually will have your specificity information on them.
That's a good tip. Thanks, Kelly. We did have one question come in, and I'll just read it real quick to see if we can get an answer or if we can get back to this listener. So they are asking, if the patient has heart failure and a rheumatic valve disease, does the heart failure automatically get considered rheumatic as well?
Kelly,
I'm
do you
not
want me to
sure.
do that, or do you want
Yeah,
to?
go ahead. Go ahead.
Yeah, there was some thought out there for a while that that would cause a link, but that is not the case. If the patient has a rheumatic valvular disease and they have heart failure, we still need for the provider to make that link between rheumatic heart failure and the valvular disease and the heart failure.
Thanks, Elise.
Mhm.
Lots of tricky bits here with this area of coding. So thanks so
We
much. I
could,
think that, oh, go ahead. Sorry.
I was going to say we could literally talk forever on all the idiosyncrasies with cardiac.
All right. All right. Well, I'm going to wrap up the poll. And thanks again, Kelly and Elise. I know that tool is going to be handy for folks to have, and lots of good reference material in these slides for folks. And the slides are in this live format, and then we'll also be posting those on the OC website, so folks can download those after the fact. So let me close out the poll, and we're going to move on to what's new with OC. And that is, we want to let you know that Decision Health has an upcoming conference, the Home Health Quality Outcomes and Documentation Conference. And this conference is geared toward home health quality managers and clinical supervisors, and will focus on how to positively impact your home health agency's quality outcomes and ensure documentation compliance and proper payments. The conference runs from September 16th through the 18th, and that's in Charlotte, North Carolina. If you register before July 16th, you'll save up to $100 with the early bird discount. And if you're an OC member, you can save an additional $100. You can follow the link in the handouts to register. I think there's going to be a lot of good things. I think Kelly is speaking at this.
Yes.
So, you know, we're excited to hear that. You know, there's some good speakers there. So thanks. Looking forward to that. Well, we hope you enjoyed this episode of OC Talk. Thanks to Elise and Kelly for all the great information, and thanks to all of you for joining us. We hope you will join us again for our next call on July 22nd. In the meantime, if you'd like to re-listen to this episode or to a previous one on the go, you can now find OC Talk on your favorite podcast app. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much to everyone for listening, and we hope you have a great afternoon, and we'll see you next month. Take care, and thanks again, Elise and Kelly.
You're
Thanks, Jan.
welcome. Goodbye, everybody.
Bye.